Hello, viewers. Today again we are with Dr. Tuteja Talk Show. Today's guest speaker is an eminent childhood cancer specialist from Bangalore, and he is going to talk to you about childhood cancer causes to cure and then beyond to it. Dr. Intezar Mehdi. He is MBBS GNB MRCPS from UK, FRCP from UK, Director and Head of Department Senior Consultant, Department of Pediatric Hematology, Oncology, and BMT HCG Cancer Center, Bangalore, India. He was Executive Committee member in IIP BPS in 2017, Executive Committee member IIP PHO Karnataka, Chapter 2017 until date. IIP PHO CME National Advisory Board, ISBMT Membership Committee. Lot of achievement of Dr. Intezar ji, faculty in local, state, national and international conferences. Areas of interest, hematolymphoid malignancy, leukemia and lymphoma, thalassemia, aplastic anemia, bone marrow, solid tumor and BMT. He is reviewer of Pediatric Hematology Oncology Journal in Indian Journal of Child Health. He is editor of Journal of Precision Oncology, live member of IIP, IIP BPS, RCPCH, IIP PHO chapter, IMA, KCISHBT. He is member of Indian Society of Blood and Bone Marrow Transplant, actively involved in academic and social activities, faculty and program director, has publication in reputed journal, presented various papers in the national and international conferences. Our aim of life is to update the society by Dr. Tuteja Talk Show and our guest faculty. They are devoting their time from their practice. If you like our approach, subscribe the channel so that you get the latest information directly. Your suggestion, comments are always welcome for the betterment for the society. So we start the discussion with Intezar ji. How common is a child cancer?
Hello, sir. Good afternoon, viewers. And it's indeed my privilege and honor to be here today on Dr. Tuteja Talk Show. I've been following this channel for quite some time, and I've seen so many eminent speakers talk on various topics. First of all, thank you to sir for inviting me today here. And today we are going to talk about childhood cancer. So, the moment we hear childhood cancer, the first thought which comes to our mind is whether cancer really exists in children. Not for the pediatric fraternity, but at least for the common man. Fortunately, for those families where children are not affected with cancer, cancer was believed as a disease of the elderly in the past. But now we all know that cancer does occur in children. Fortunately, it is relatively uncommon. So, it is said that the childhood cancer incidence worldwide in our country is less than 5%, precisely 1.6 to 4.8%. But if you look at as a whole, approximately 1 in 10,000 children are affected with cancer. So if you take that statistics, so out of 100 people who are affected with cancer, less than 5% will be children. But in general, out of children below 15 or 18 years of age, 1 in 10,000 will get affected with cancer. So considering our country's population about 145 crores, 30% of our population is below 15 years. So that is approximately 45 or 50 crores. So if you take it as 1 in 10,000, then you can imagine how many children will be diagnosed with cancer every year. Right now, as per our reporting system, about 50-60,000 children are affected with cancer every year. But maybe there is under diagnosis and under reporting because we do not have a very robust nationwide registry to record this, but it's probably a little more than this. So that's the whole burden of cancer in children.
So what are the types of cancer you have seen from and how it differ from adult in children?
So, if we talk about cancer in adults, generally we know that in men we come across lung cancer, prostate, colon, stomach, and in women we usually come across breast cancer, cervical, uterine cancer, and few other common cancers like stomach and colon.
Mm.
But in children, we don't see any of these cancers. So the top three cancers in children are leukemia, which is commonly called as blood cancer, or lymphoma, which is a cancer of the lymph glands, and brain tumors. So these are the top three. These three together constitute about two-thirds of all childhood cancer.
Mm.
Leukemia alone constitutes about one-third of all childhood cancer. So to make it simpler, leukemia, lymphoma, and brain tumors are the three most common cancer in children. And these are followed by a few other tumors. For example, bone tumors, what we generally call them as sarcomas, like osteosarcoma, Ewing sarcoma. Then you have soft tissue sarcoma like rhabdomyosarcoma. Then you have abdominal tumor, kidney, Wilms, neuroblastoma, eye tumors, and liver tumors. So basically, I always, when I am teaching my fellows and colleagues, PGs and junior doctors, I always tell them that pediatric hematology oncology is not very difficult, because in pediatric oncology you have 10 or 12 different types of cancer. These are the most common ones. If you master them, then you are fine. But of late, in the last 5 to 8 years, I can say, we have started seeing some of the adult cancers which we never used to see in children before. For example, I have seen thyroid cancer, colon cancer, and stomach cancer and breast cancer in children in the age group of 14 to 18, which we
Mm.
never used to see before. So it's very unfortunate why these cancers are coming in children in this age group. Whether it's got something to do with our environmental thing or lifestyle, we'll discuss in the next few minutes. But then we
Yeah.
have started seeing some of the adult cancers in the children nowadays. But then the common ones are leukemia, lymphoma, and brain tumors.
Mm. Why do children get cancer then?
Sir?
Why do the children get cancer? Why do the
Ah,
children get cancer?
yeah, that's a very important question we need to answer, sir, because majority of the time the cancers in adults are very much related to genetic, environmental, as well as lifestyle factors. For example, smoking is directly linked to lung cancer and many other types of cancer, stomach, bladder, many other lifestyle. But in children, majority of the time, 95% of the time, we do not know what is the exact cause of cancer. Obviously, lifestyle cannot play a role in a child who is 2 or 4 year old, right? We have just
Mm.
started feeding the child with the weaning food and home food, and there is hardly any other lifestyle to matter. Environmental influences also take a longer time for causation of cancers generally. So children exposure to environment in young age, 2 years, 5 years, or 10 years is not good enough. So lot of theories have been put forward, but unfortunately none of them have been proven. So 95% of the time we do not know why children get cancer, but in 5% of the patients, maybe some genetic factors play a role. For example, children born with Down syndrome have increased incidence of some types of cancer, especially leukemia. Children having new hereditary neurofibromatosis, for example, some other syndromes like Bloom syndrome, Beckwith-Whitman syndrome. So these children have increased incidence of developing cancer. Apart from this, let us say vaccination, for example, it's a very hot and debated topic. Hepatitis B vaccine is universally given to all children to prevent causation of liver disease and liver cancer, which can occur in adults. So that is one of the preventive strategies which we can do. But then we don't get generally hepatocellular carcinoma in children because of not giving vaccination. So it's more of a prevention in the adulthood. Other than that, ionizing radiation, exposure to ionizing radiation. For example, when the mother is carrying the baby, or accidental exposure or therapeutic exposure of ionizing radiation. Let us say child is treated for a type of cancer, let us say Hodgkin's lymphoma in childhood, where he has received radiation to the neck. Then he can develop second cancer in that radiation field. So these are all causes in 5% of the patients, but 95% of the times we do not have a known cause why children get cancer.
Do you think that the incidence of cancer in children is increasing?
So, sir, if we see, like I mentioned in the beginning of our conversation, we do not have a robust database where we can have a recording of the entire nation's childhood cancer database telling that these many children get affected every year. Majority of the time, like when I started my career here in India about 15 years ago, we used to read only some papers by some of our fellow colleagues describing about the instances in individual institutions. Let us say All India Institute of Medical Science, Tata Memorial Center, or Kidwai Hospital in Bangalore, where they had a registry. They used to talk about only incidents in these places. And even the cure rate, unfortunately, at that time reported in our country ranged only from 20 to 30%, because many children did not reach the respective cancer center. Unfortunately, they did not get the treatment at that point of time. Of late, what has happened is through collaborative efforts, especially through Indian Academy of Pediatrics, our IAP is a very strong body, and now we connect with each other and we are, trying to reach out the general pediatrician and family physician that how they have to diagnose these cancers early. So that's why we are probably getting an increased number of cancer in children. That is one distinct perspective. The other perspective is which is very much debatable. As of now, we do not have enough data to say that whether the changes in our environment, whether the changes in our lifestyle have actually increased the incidence of childhood cancer. We do not have enough data to back that. So as of now, we feel that the incidence of childhood cancer might have increased in our country as well as globally, as per reports from WHO and International Pediatric Oncology Association or our country association, maybe because of better awareness and more of diagnosis and reporting and maintaining the database rather than a true incidence in increase of cancer in children.
Hmm. What are the early signs and symptoms in children so that the parents, it can help the parents to uh,
So
come to the
majority of
doctor
the
in
time,
time?
yes, sir, yes, sir. So majority of the time, the signs and symptoms of childhood cancer are non-specific and they are very subtle. So, for example, some of the common signs and symptoms which we see in children with very common illness can be manifestation of childhood cancer. Let us say I just mentioned that leukemia, lymphoma, and brain tumors are the three common cancers. Let us take leukemia for example. So, blood cancer child is not going to come and tell us that I am having cancer, isn't it, sir? Similar to, for example, we read textbook picture of typhoid fever and dengue fever, but it's not the same in the clinical practice. So, for example, leukemias, the most common presentation of leukemia is fever. Fever is such a common symptom in childhood, right, sir? All children will get fever, and majority of the time it is viral, and they get better in 3 to 5 days. When the fever does not get better by 5 to 7 days, and based on the clinical situation, we start looking at possible causes. For example, the common illness, typhoid, dengue, urinary tract infection, and few other infections based on the clinical scenario. But if the fever is persistent and the fever goes into the second week, especially when there is no focus of infection clinically, and if you have ruled out the common illness like typhoid, dengue, UTI, for example, then that's a red flag. That may be a harbinger of underlying malignancy. I think our Nelson textbook of pediatrics, it says that if you have a FUO and if you do a blood investigation like ESR, and if ESR is more than 100, there are only three differentials. One is tuberculosis, two is connective tissue disorders or autoimmune disorders, and the third one is malignancy. So, if the fever is persistent for more than couple of weeks, then you should consider leukemia as one of the differential diagnoses. The other signs and symptoms may be, for example, glands in the neck. Having said that, glands in the neck is such a common problem in childhood, especially the anterior submandibular glands, which can be just inflammation because of tonsillitis or simple throat infection. But if the glands are persistent, especially in the posterior part of the neck, or if you have a supraclavicular lymph node here or in the axilla or groin, especially if it is persistent for more than 2 or 3 weeks, sometimes you may come across bleeding episodes, like children may have, petechiae or ecchymosis, that means the skin bleeds, or they may have organomegaly like liver or spleen may get enlarged. Sometimes they can have bone pains, loss of appetite, loss of weight. These are the usual signs and symptoms of leukemia. That is a red flag. And for lymphoma, majority of the time, Hodgkin's lymphoma, for example, presents with very slow and incidence onset. So children may have glands in the neck which can go on for weeks or months. And because they are asymptomatic, most of the times there is no pain. And they may not have any associated fever, loss of appetite, or loss of weight, what we call it as B symptoms. That's why many times, these glands may go on for 3 to 6 months. So if the glands are there in the neck for a very long time, it's better to get an opinion, a simple clinical examination followed by ultrasound. But if in doubt, get a excision biopsy of the lymph node. Please do not ask for FNAC. FNAC majority of the time will miss the diagnosis. Brain tumors. Now, early morning headache, that is the classical presentation of an early onset brain tumor. But headache is such a common symptom in children, isn't it? So, for example, a child doesn't want to go to school in the morning, will just get up and say, Mom, I'm having a headache, I don't want to go to school. So, how do you differentiate this headache from something which can be a brain tumor? If the headache is persistent, it is there in the morning, wakes the child from sleep, and then followed by vomiting, and does happen not only on the school day but also in the holidays, then if this symptom can be a red flag, a quick clinical examination, because by the time you get diplopia, double vision, blurred vision, neurological deficit, many times we have missed the diagnosis for a long time. Bone tumors, I want to touch here, sir. For example, in bone tumors, majority of the time the bone tumors present between the age of 12 to 18 years, which is the adolescent growth spurt. And this is the time many children may be having what we call it as growing pains. So if the child comes back from school in the evening and is complaining of leg pain, and then we pass it as a growing pain, how do you differentiate from a bone pain, which is because of a bone tumor, which does occur in this age? Because by the time the swelling comes around the bone area or joint area, by then the tumor is quite advanced. So the early red flag is if the child wakes up in the middle of the night because of pain. Night pain is characteristic, and especially if it is focusing only on the one leg. For example, the commonest area for osteosarcoma, Ewing sarcoma is around the knee joint. That means either the femur or tibia is usually involved. So the child is always complaining of only one leg pain, right leg only, waking the child in the middle of the sleep, then it is pathological unless proved otherwise. If X-rays don't give you the answer, better to get an MRI investigation, which is a non-invasive and a non harmful investigation, which can be done to pick the tumors in early stage. Majority of the child is complaining of pain today, right leg, tomorrow left leg, today back pain, tomorrow headache. It's unlikely to be pathological, but if the child is focusing only on one area, so these are some of the signs. Eye tumors, for example, retinoblastoma, majority of the time the red eye reflex is very important in the newborn period and in the early childhood when the pediatrician is checking. So if you see a white eye reflex, or sometimes the photographs we see, so that time you can pick up the retinoblastoma early unless the tumors become much bigger in size. So these are usual. Sometimes some brain tumors, especially in the posterior fossa, may present with gait disturbances. Sometimes there may be behavioral abnormalities. Sometimes some children will present with diabetes insipidus, for example, precocious puberty. So these are the other conditions where brain tumor may be a possibility. So always, keep your eyes and mind open. Always, our teachers taught us, eyes do not see what the mind does not know. And our teachers taught us always that even if you are a super specialist or a subspecialty consultant, for example, focusing only on pediatric hematology oncology, please remember to see the child as a whole. Don't focus just only on your area of interest, because sometimes you have to focus the child on as a whole, not just think only about your specialty.
Mm. Is there any role of heredity and genetics? How
So,
do you look at?
like I mentioned, sir, some of the conditions like Down syndrome, children diagnosed with Down syndrome can have increased incidence of leukemia, especially AML and sometimes ALL. And some children born with, for example, Beckwith-Whitman syndrome can have increased incidence of Wilms tumor. Some children born with, for example, hereditary neurofibromatosis can have increased incidence of eye tumors, especially optic nerve glioma and osteosarcoma, and some of the rare other syndromes like Bloom syndrome, ataxia telangiectasia, and few others, which we don't come across so common in practice, only in those conditions. Okay, there may be a family history of cancer, whether that family history of cancer is relevant for us. So, for example, if the mother or father is diagnosed as retinoblastoma in childhood, and if they have had a child, and especially the retinoblastoma is bilateral, then there can be hereditary association. For example, if the parents are diagnosed with early onset cancer disease, that means in 30s or 40s, if they have developed breast, ovarian cancer, or a lung cancer, and there are two or three family members affected, then there can be a genetic association. So, those children, we have to take a detailed family history, probably draw that family tree and see whether there is a paternal origin or the maternal origin of this disease. And such patients may need genetic counseling and genetic screening. But overall, majority of the patients, there is no genetic or hereditary link. But in these focused population where we already know that either there is a strong family history or the child is affected with one of the genetic syndrome which has an increased chances of developing cancer, those children should be regularly screened and follow up so that we can pick up those cancers early stage.
How do you screen these children and what you recommend for the screening?
So this is a question which is often asked to us, and also whenever we go in the public forum, on when we are talking to pediatricians or when we are going to schools and colleges for talks regarding awareness. So as you see, sir, the WHO guidelines even today do not recommend screening for normal children for childhood cancer. As you know, sir, as pediatricians, we are all pediatricians first. We all know that globally, even today, our main problems are malnutrition, infections, immunization. We are still focusing on these areas because these are the killer things globally. Cancer, as you know, as a cause of non-communicable disease in children is still a small problem, but we all know how deadly this is, and we all want to focus on this and improve the outcomes. But as of now, globally, the recommendation is not to screen normal children in a camp for cancer. Like for example, sir, in adults, we go to camps and we do breast cancer awareness. So we'll do simple mammography, for example. For colon cancer, you can do stool occult blood or you can do colonoscopy. For lung cancer, you can ask for an imaging from the chest. For prostate cancer, you can do a simple blood test, PSA, to start with. So these are all the recommended screening tests in adults. In children, we do not have a one simple blood test which can screen for childhood cancer. For example, this blood test can screen. No, we do not have a single scan which can say this will cover for all the these things. So we don't have any screening test. But like I mentioned, the target population, let us say a child affected with Down syndrome or one of the other hereditary syndromes where there is an increased risk of cancer, in those children we will do screening tests and regular monitoring. Let us say there is a strong family history of cancer in a family, so those children we can start doing screening tests. So only in the focus population, otherwise in general population it's not recommended and we don't do it.
Great. How do you diagnose cancer in children?
So let us take the example, sir. Let us say I am suspecting that a child has come with a 10 days history of fever and then he had some glands in the neck and he has some bleeding spots. I examine him and I find that there is bilateral posterior cervical lymph nodes and liver and spleen. So I am suspecting that this child may be having leukemia. So to start with, my first investigation will be complete blood count and peripheral smear examination. Majority of the time, the blood counts will tell us most of the answers. We always say that peripheral smear is the window towards the bone marrow, and bone marrow is the factory where all the cell lines are manufactured actually. So usually in leukemia you may find anemia, thrombocytopenia, and leukopenia or leukocytosis, one of the two. Either the WBC count is very high or low, and sometimes you may find cancer cells present in the peripheral blood. Makes your job easy. If you don't and you only find that the counts are very low, hemoglobin platelets and WBC is high, you might have to do a bone marrow examination most of the times to confirm the diagnosis. Once you do the bone marrow, you see the cancer cells morphologically, then you do some special tests on the bone marrow called flow cytometry, genetic and molecular tests to classify what is the type of leukemia. Let us say I am suspecting a brain tumor, then the first investigation I am going to do after a clinical examination is an MRI brain with contrast. That will tell me what is the type of tumor and where is the tumor setting. Nowadays, with advanced radiological investigations, many times our radiologists will be able to give a differential as to what is the possible tumor in that location. For example, in the posterior fossa, you may be seeing medulloblastoma or ependymoma. If you have a supratentorial tumor, you may be seeing a glioma, which can be a low grade or a high grade glioma. Sometimes you can see high grade glioma in the brainstem also. If you are suspecting an abdominal tumor, let us say Wilms tumor or a neuroblastoma, your first investigation after clinical examination will be an ultrasound abdomen, which will tell us that the tumor is renal or suprarenal. Then subsequently, you will go ahead with do a CT abdomen, or you might do a whole body PET CT scan for staging, and then you need to do a tissue biopsy from the tumor. Usually in Wilms tumor, without biopsy also we can treat, but in neuroblastoma you'll have to do a image guided tissue biopsy, and then you send it for special test IHC for confirming the diagnosis. In lymphoma, like I mentioned, Hodgkin's lymphoma predominantly has painless glands in the neck, may or may not have fever, night sweats, weight loss. We do ultrasound followed by an excision biopsy of the lymph node and do IHC on that lymph node to confirm the diagnosis. Non-Hodgkin's lymphoma can have a more acute presentation, like Burkitt's lymphoma, typically presenting with jaw tumor or abdominal tumor, where children are more sick and they are in tumor lysis. So quickly we have to stabilize the child and side by side start treatment and do the diagnosis. For example, bone tumor, I mentioned, child will have night pain, which is characteristic, and we do an MRI. Let us say around the knee joint patient is having, then we do an MRI. MRI will show us where the tumor is. What is most important is the management of childhood cancers is always multidisciplinary. That means multiple people need to be involved. Our primary general pediatrician is our first person who has referred the patient to us, and he is part of the care always. Other than that, the pediatric oncologist will need help from other specialists like radiation surgical oncologist, depending on which tumor we are treating. For example, if you are treating a brain tumor, a tumor board multidisciplinary team meeting where pediatrician, pediatric oncologist, radiation oncologist, surgical oncologist, neurosurgeon, and many other people need to be involved in that. So always it is better that the treatment planning and the diagnostic planning is done in the center who is going to ultimately handle the patient. What I am trying to say is, if you as a pediatrician suspected that the child may be having a bone tumor and you did an MRI and you found that there is a tumor at the lower end of femur, query osteosarcoma, it is always better for you to refer the child to the pediatric oncology center where the child is going to be managed, because the biopsy need to be planned in a manner which is not going to hamper the chances of limb salvage surgery in future. Because if the biopsy is not planned properly, the chances of doing a limb salvage surgery for the child later fails. So it's always better the child is cared for in a center which is equipped to handle all these things. So these are some of the diagnostic tests how we diagnose the different types of cancer in children.
A common question is that why the two cancer behave differently to the treatment.
Yes, sir. That's a very perplexing thing, isn't it, sir? You would agree with me that even in, for example, when general pediatrics, let us say you have a 5-year-old child with tuberculosis, two 5-year-old children whom you have seen in the same week with tuberculosis. You start treatment, anti-tubercular treatment, same protocol for both of them. One of them may behave differently and the other one behaves differently. So I
Yeah,
think
yeah.
one is the disease biology. Even though externally we have diagnosed the same problem in two children, they may be of same age group, they may be having same weight and height parameters, you have used the same drug, same dosages, but they may behave differently because the disease biology is different internally how we behave. And second thing is, everybody's body is also different. So sometimes this is a question we always ask. For example, let us say acute lymphoblastic leukemia in children, the standard risk, 85 to 90% of the children get cured completely if we treat them correctly. But
Hmm.
why those 10% children don't get cured? Why those 10% children, don't get cured and they don't respond to treatment? We still don't have answers. So many times I always say that sometimes we have more questions than answers as we
Yeah.
go deeper and deeper. So it is always good that we do a detailed counseling to the family and say that generally most children are expected to do well, but every child is different. How the child is going to respond. Sometimes we have twins and both the twins will be entirely different when it comes to
Yeah.
their eating habits, sleeping habits. Similarly, if they have illness also, one child may become more sicker than the other.
Hmm.
There are many things which is difficult to answer.
So, how do you manage these children and their family dealing with the cancer at different ages? So, it
I
is a
think
lot of
that's the
issues.
Yes, sir. I think that is very, very important, because See, if your child is like below 5 years of age and child is affected with leukemia or brain tumor, majority of the time our communication is with the family, because child at that age group is not going to ask us much. Okay, child is about 4 5 and little bit smart, he or she may ask, when can I go home, can I eat this or not, can I go back to my nursery, play, school, whatever, simple things. So that age is different, you only talk to them only that much. But for example, the child is between 5 to 12 years of age, depending on the understanding level of the child, depending on what background they come from, they will have different questions. For example, a 10-year-old may be more knowledgeable than another 15-year-old, and he or she may ask, doc, do I have cancer?
Hmm.
Doc, I just checked on Google. You are a pediatric oncologist. That means you treat children with cancer. My parents never told me about all this. Do I have this problem? And then you have another challenge in the age group of 12 to 18, what we call it as the adolescent age group, which is your area of expertise, and we have learned so much from you, sir.
Hmm.
So, in the adolescent age group, it's a bigger challenge, because many times the families are telling us that please do not tell anything to my child, girl or boy, because they will get shattered and they will go. But the thing is, majority of the time those children are street smart, and by now, because of the social media era, they are more knowledgeable than us. So 15 or 16-year-old boy or
Agree.
girl has access to net, and they have read everything about it, they have read
Yes.
their reports. So we have to take the parents into confidence and tell them that it's better to tell the truth in a polished way to the child, because not telling anything to them, then they will have their own assumption and presumptions and get half knowledge from this media, and they will say, oh, I think something is grossly wrong with me, I think I'm going to die. That's why nothing is
Yeah.
being told to me. My parents are not telling anything to me. The doctor is not telling anything to me. So something is wrong. So I think it's better to, counsel them. We need to spend a lot of time. And even with the families, I think we in pediatrics, we have learned that counseling and a detailed counseling and sitting with the patient family and listening to them, not just talking by yourself. That is an art which we have learned from our teachers, and over a period of time we have had our own methods. So I think you need to spend a lot of time with this patient family. I always tell this, that if a child comes with cold, cough, fever, the parents are so much worried. We have all been parents when our children were young. If our child gets normal fever, we get so much scared about it, right? We just run to the doctor, we call the pediatrician in the middle of the night. Imagine the family, how much of psychological trauma they are going through when a child is diagnosed with cancer. So we need to spend a lot of time with them, be very truthful and transparent with them. Don't give false hopes. Please discuss reality, and sometimes one session is not enough. You might have to sit again and again. You need to have a lot of patience to make them understand.
Communication and counseling is very important in any medical field, including pediatrics and adolescent. Uh, how does it affect the growth and development of and daily activity of the children who are suffering from the cancer?
So, sir, obviously, when we are treating these children with chemotherapy, drugs, medicines, obviously, majority of the time their appetites are poor and they may not be able to eat well. And some children, they may lose weight also. But usually, the loss of weight is not more than 10-15%. And once the treatment is over, they will have catch up growth. Generally, development per se, let us say you have a child who is only 1 year and diagnosed with leukemia, and I started treatment, child had just started walking with the support. Generally, the development, whether it is the brain development, gross motor, fine motor, social and other things, are not affected much. It's more of the physical growth which may be affected, that means the weight gain and sometimes the length gain, height gain. So that may be affected during the acute phase of treatment, especially if they are on intensive chemotherapy. But majority of the time, once this treatment is over, they can have a catch-up growth. The other thing is, like I mentioned, depending on what age group the child is, let us say child is only 5-6 years or below, when they had just started going to nursery or LKG, UKG. So majority of the time they can take a break from school and focus only on the treatment. But for example, if I have a child who is 15 or 16, is about to give 10 standard board exams, or sometimes 17, 18, 12 standard board exam, and suddenly they are diagnosed with this problem, then we need to discuss and see how we can balance both the education, attending schools and exams, versus giving treatment. So if you have a less intense treatment, and if the treatment can be scheduled in such a way that the education is not affected, we try to do that. But if you have a very intense treatment, for example leukemia or bone marrow transplant, and it is clashing very much with the board exams, then we try to counsel them and say that prioritize this today over your exams, and next year you can always go back and give the exam, because right now this is more of a threat to us. So like that we actually manage the growth development and other things during that treatment.
How much is the survival rate and what are the best outcomes in these
So
childhood
sir,
cancers?
yes, sir. Fortunately for us, childhood cancer is very much curable. If you see the global data, almost 80% of the children with cancer survive today. The global data, the Western data. In our country, there is no global, Indian scenario to say. But if you see the bigger centers, now fortunately we have more than 500 pediatric hematologists, oncologists practicing across the country, and at least in those centers where the best possible care is given to these children, both public sector as well as private, the cure rates described are in excess of 70%, which is very very motivating for us. But if you dissect it further and see, some of the childhood cancers like blood cancer, leukemia, ALL, which is the commonest, the cure rates are more than 80%. AML is about 50 to 60%. Hodgkin's lymphoma has a cure rate of more than 80 to 90%. Wilms tumor has a cure rate of more than 90% in the majority. Non-Hodgkin's lymphoma about 80%. Brain tumors, depending on which type of tumor, the cure rates may vary from 30 to 80%. Other solid tumors like neuroblastoma, sometimes, if it is metastatic, it has a very dismal outcome, 30 to 40% cure rate. But localized ones do well. Bone tumors, if they are localized, there is a survival rate of 70 to 80%. But if they are metastasized, that means spread to other parts of the body, then the cure rate will come down to less than 30%. So overall, we can say that in our country also, most of the cancers we are able to cure in 70 to 80% of these children.
That is good that we are treating in a very well way our children and the outcome is better. So how the leukemia is managed?
So, leukemia, majority of the time, the main modality of treatment is chemotherapy. And once we diagnose the leukemia, we classify it whether we are dealing with acute lymphoblastic leukemia or acute myeloid leukemia. And then we risk stratify whether we have standard risk, medium, or high risk. Most of the children will be started on chemotherapy, which is nothing but medicines which are given by intravenous route and sometimes orally. And they have phases of treatment. First month of treatment is called as induction, which is generally for about 4 weeks, 1 month, where children might have to stay in the hospital for few days and we discharge them once they are better. And then we have 5 to 6 months of intensive chemotherapy followed by maintenance. Most children with leukemia can be cured with chemotherapy. Most of them do not require bone marrow transplant, and most of them do not require radiotherapy. If we are talking about brain tumor, it's a multimodality treatment, surgery by neurosurgeon, and then we have chemotherapy and radiation. Bone
Hmm.
tumors also a multimodality where you have chemotherapy, surgery, and in some types of tumor, radiotherapy may be required. Hodgkin's lymphoma is one malignancy where we almost always cure, whether it is stage 1 or stage 4 disease, and most of the time it is with chemotherapy, and we are not giving much of radiation nowadays to children with the Hodgkin's lymphoma.
Mhm. What are the recent advances in management of childhood cancer?
So I think what we have learned in the last 50 to 60 years is from life-threatening disease, leukemia, about 50, 60 years ago, less than 10% of the children used to survive. Today we have reached where more than 90% of children with leukemia, especially ALL, survive. Now what we are trying to do is we want to continue to improve the cure rates in children, but want to minimize the long-term toxicity. For example, in the past, lot of leukemic children and lymphoma children used to get radiotherapy, and this radiotherapy had a detrimental effects with growth, development, puberty, hormonal issues, and second cancer in adolescent and adulthood. So now gone are the days where we give radiotherapy for children with cancer. Other than that, now we have a lot of molecular tests and genome is coming up. In the adult, almost most of the cancers they get a genetic testing done, and they will find out a target mutation which has a targeted therapy or a immunotherapy. So the blanket rule of giving chemotherapy to everyone is going down. But in children, we have some immunotherapy and targeted therapy medicines, but they are useful in recurrent or advanced setting or where chemotherapy does not play that much of a role. For example, in recurrent leukemias, we may add immunotherapy. For example, in upfront neuroblastoma stage 4, we may add immunotherapy. For example, in recurrent solid tumors, we may add target therapy where we can focus only on that particular mutation to target to improve the cure rate and outcomes.
Hmm. What will you tell us something about bone marrow transplantation
Yes,
and
sir,
what are
that
the
is another area of my interest and expertise. And this bone marrow transplant is a medical procedure, unlike kidney transplant or liver transplant, where it is a surgical procedure. Bone marrow transplant is generally done by a pediatric hematologist, oncologist, or an adult hematologist, oncologist. So basically, this has two types: autologous transplant and allogenic transplant. Autologous BMT means patient's own stem cells are used for transplant. Allogenic transplant means where we use a donor stem cells. So autologous transplant will be useful in, for example, oncological problems like lymphoma, especially if it is advanced stage or if it is recurrent, or for example in tumors like neuroblastoma or in brain tumors. Allogenic transplant is the real transplant, and this is a game changer. I say that because this is implicated in lot of diseases. For example, leukemia, especially if they are high risk or if they are advanced or if they recur. And in most important thing in our country, unfortunately, is the thalassemia capital of the world. We have the maximum number of thalassaemic children in our country. And at this point of time, when gene therapy still is not available for everyone, bone marrow transplant is the only curative option available for cure for children with thalassemia. Aplastic anemia, bone marrow failure, Fanconi anemia, these are some of the other conditions where bone marrow transplant has got a role.
Hmm. What is the process of BMT?
Sir,
What is the process of BMT? Bone marrow
so let
transplantation
us
process.
yes, sir. Let us talk about allogenic transplant. Let us say I have a child who's 3 years old with thalassemia, and then I have a 6-year-old sibling of that child who's not affected with thalassemia, and they are both matching with each other. HLA typing is full match. Then what I do is I do something called as a pre-transplant workup, which has a general clinical exam, a series of blood tests, ECG, echo, and viral serology, HIV, HBs, HCV, and few other viruses for both donor and recipient. Then after that, I'm going to admit this child who is having thalassemia in a bone marrow transplant unit, which is a single room HEPA filtered unit where the infection cross infection cannot come, external bugs cannot come inside, and the child is there with the mother for almost 1 month. They cannot come out. The doctors and nurses will go there after wearing scrub suits and only examine the child and come out. So we will give some medicines called as conditioning chemotherapy. This medicine is basically going to medically create space for the new marrow. So they are myeloablative chemotherapy. For example, busulfan, fludarabine, cyclophosphamide, total body radiation. These medicines will actually medically empty the marrow. That means we give these medicines for 1 week. After that, the counts become zero. Hemoglobin, WBC, platelet, everything is zero. So obviously, for hemoglobin, we give blood transfusion, PRBCs. For platelets, we keep giving platelet transfusion, but WBC will remain, very zero. Then on one day, after the conditioning is over, after 1 day of washout period, I will give the stem cells of this donor like a blood transfusion to the patient. After that, the next 2 to 3 weeks is the most difficult part of the transplant. Here, the blood counts is going to be zero. Child is at risk for infection, bacterial, fungal mainly, and sometimes viral. There will be a lot of mucositis, problems with nutrition. So here, my general pediatric knowledge comes into role. How I have to take care of this sick child, multidisciplinary team approach. And after about 15 days, the blood counts will start coming up. Once the blood counts have come up, then I make a test to see whose bone marrow is working now. So once I know that the donor's marrow has started working, that means the thalassemia will get cured. The child will require some follow-up. After 1 month, they get discharged. They will be on follow-up for 3 months, 6 months, 1 year to be on immunosuppression medicines. But after about 6 months or 1 year, all the immunosuppression medicines will be stopped, and this child will be cured for all their life. Let us say I transplanted for thalassemia, then the child becomes transfusion free, and after the immunosuppression medicine is stopped, child is not going to be on any medication for rest of his or her life.
Great. So, role of BMT in pediatric oncology.
So, like I mentioned, sir, in the benign disorders, allogenic bone marrow transplant has more role. Like I mentioned, thalassemia, aplastic anemia, inherited bone marrow failure syndrome, and some of the immunodeficiency disorders, like for example, severe combined immunodeficiency, Wiskott-Aldrich syndrome, for example, and some of the metabolic and storage disorders also. Allogenic transplant has a role. other than the benign hematology, in the oncology setting, majority of the time the leukemias, the bad leukemias, that means the infantile leukemias, the ALL and AMLs, when they relapse or they are high risk, they have a role. And in oncology, autologous transplant has more role. For example, in neuroblastoma, when they have relapsed or high risk, and in lymphomas and some of the brain tumors.
Hmm. Can you narrate some incidents which was stressful for you in your practice?
Stressful message, sir.
Yeah.
I think if I remember, yeah, so I had a child who was having this diffuse brainstem glioma, and initially we have given some radiation and concurrent chemotherapy, and then the child, has come back in 6 months with advanced disease, and we had a tumor board discussion. We all know that this is a very difficult situation, and most of the children will not survive from here. So we had a very detailed counseling with the family. We involved our counselor, psycho-oncologist also. The family was okay to accept it, but this child was 12 years old. So I still remember, he just told me, "Doc, I want to speak to you without my family." So I told the family, let him talk to me. So I had a good rapport with the child. So he just asked me, "Doc, I want to ask you something. You shouldn't lie to me." I told, "Yeah, please go ahead and tell me. Am I going to die?"
Oh,
So, I'm sure Tuteja sir can understand what will be the kind of, emotions that we'll go through
yes,
at
yes.
that point of time.
I
I
can
did not
understand.
have an
Difficult
answer
to
for,
answer.
sir. I
Difficult to answer.
very difficult situation to be in. I cannot lie to him, telling that don't worry, everything is going to fine. And I cannot tell him that yes, you are going to die. There is no straightforward answer to this
No,
type
no,
of
no.
situation. So I think it was very stressful for me. What I did at that point of time is I spent a lot of time with the child, and I made sure that he understands that what is life and death and eternal peace. I tried to
Yeah.
dissect it into smaller things and say, for example, let us say by medically we know that he's going to live for another 2 3 months. I wanted to understand from him, if we have 2 months in life, what we want to do. For example, I want to go to this show, I want to wear this clothes, I want to go to this restaurant, I want to meet this friend, I want to be at home, I don't want to be at the hospital. These are small little things which we can still do. For example, he wants to go to Tirupati to visit, or he wants to go to Golden Temple in Amritsar, or he wants to go to Medina to visit, the Holy Shrine. So, there will be very small things which they still can do if they have that little bit of time. So sometimes we should focus on that. But it was very stressful.
Hmm. So, I think that that was motivational and memorable for you for the talking to the child who is asking such question. And you may have some other memorable motivational uh, patient in your practice, which gives a good message for the society.
Sir, yes, sir. I am very fortunate. I have at least now 15 to 20 years of follow up of the children whom I have treated in
Oh,
India for the last so many years. So some of them, when I saw them, they were very young, 4 5 year olds, and now they are like in their 20s. Some of them have finished their graduation, post graduation. Some of them who are 15, they have got married now, they are settled, they have children, they still come and talk to me. So it's nice. But in the last 5 years, around the COVID time and around that, just before that and after COVID, there have been at least two children who have told me that, sir, आप wait करिए, you just wait. We are just going to come and join you, because they feel that they got motivated by treating children with cancer and blood disorders. So I'm proud to say that two of my patients who I have treated in the past, one is in final year MBBS and one more is in third year MBBS. Both of them are studying in Bangalore city. Both of them
hmm.
are cancer survivors. They want to take up pediatrics and then later come and train with me in pediatric oncology, and they want to join me. So there cannot be more motivating thing than this. So I have
Yeah,
told them that let God give me more time, and I should live till that age to see them. But by God's grace, I told them, once you guys come and join me, I can hand over the baton to you and you can continue the good work, and I can retire at that time. So it is
yeah,
very very motivational, sir.
yeah. That is the charm of pediatric practice, that you get the children to follow you up in the life, when they are treated and they get cured from us. and that is always a memory for our lifetime, and that gives you life when you are senior citizen. Any message you want to give to society for the children and parents?
Yes, sir. My message is childhood cancer is uncommon. Fortunately, God is always great. But in
Yes,
spite of that, some children will get cancer, unfortunately, and majority of the time, it is not possible for us to prevent it because there are not enough preventive strategies or known causes. Early signs and symptoms of childhood cancer are very non-specific and subtle. Parents need not panic and run to an oncologist to ask, is my child having cancer the moment they get fever or headache or bone pain or glands in the neck. What is important is trust your pediatrician. If you are having one pediatrician who is following your child right from the time of birth or young age for many years, they will pick up those subtle signs and symptoms which are not fitting into any of the common illness. Let us say, after all this, God forbid, your child is diagnosed with a cancer. Please do not get too much worried. I know you'll be worried as parents, but please remember that majority of the time, childhood cancer is curable. We always use a line punchline in cancers telling first time is the best time, not meaning that your child should get cancer, God forbid. But if we got a problem, first time the right treatment at the right place by the right person is very very important, because majority of the time if these cancers recur, their cure rates are not the best except in few cancers. So first time if we give them the best treatment, they will not only defeat that cancer, but they will be normal children for rest of their life. Because I always believe that 5-year disease free survival talking in adult cancers has no meaning in childhood cancer. Because if I cure the child for 5 years, what difference it makes? This child has to be normal for rest of his or her life, because we are talking about this child who is the future for not only that family but also for the society, but for also for the country at large. So we have a
yes,
bigger stake, so we are looking at a
yes.
very long term thing. So that's my
Totally
message
agree
to
with you.
all the
Totally agree
viewers.
with you. Totally, I agree with you.
Thank you,
Thank
sir.
you so much, इंतजार जी. मतलब ना तो आपने इंतजार कराया, और आपका टॉक वाज सो नाइस एंड so very clear thoughts process, and that shows that in-depth knowledge of subject with you, and experience. I am sure that all the IPNs, pediatricians across the country, parents and viewers from our country will be benefited with this talk, and they will follow the instructions, suggestion, motivation given by Dr. Saab, Dr. Intezar Mehdi, to the public, and they will wait for the thing, for the right cause. Thank you so much with being with us in Dr. Tuteja Talk Show.
Thank you, sir. Thank you
Thank
for
you
the
so much.
opportunity, sir. Thank you.
Thank you, sir. Thank you so much, sir. Thank you.
Okay, sir. Thank you.